There's a whole lot of principles here. I won't go through them all, but principles of design are important in terms of how we manage our spaces. I know some facilities now have dementia level care on the second floor of the building. I don't know if you've visited any of those. Those patients don't really get to go outside, and in the facilities I've visited, they get to go outside on the internal aspect, and there's a little bit of sort of green carpet, and that's it. I don't think that's great personally. The 2 points here I just wanted to make about design. So Canterbury, I don't work in Canterbury, Dr. Macleod does, they've just built a new facility. They've got 2 wards now. I'm not sure how many have beds, 20 beds each, is it? Yeah, 20 beds each. Circular, it's quite an amazing resource. The few things that kind of went wrong, because it is an amazing space, everyone has a card that they hang around their neck, and it's quite impressive. So if you're a patient there, your card will get you into your room and your room only. So in terms of intrusions, like Valerie, she couldn't go and wander into someone else's room because her card wouldn't work on their door. So that's quite marvellous really when you think about the technology. And the staff obviously all have cards as well that go into everybody's room. Some of the problems they've had with this though is some of the early onset dementia cases, they look quite young and they look like staff, and of course as you're leaving or entering the facility with your lanyard, then you see someone coming the other way who's also got a card and they've wandered out a few times. So I think they're now thinking about getting different coloured cards for the patients and the staff. So it's just a design thing, isn't it? And I think I was told that the level of falls is actually probably increased because the space is a lot bigger, so the nursing staff are less close to the patients, and so there's the possibility there. And certainly the nursing staff were doing a lot more miles in their rounds. They had pedometers and things measuring themselves. So, but overall, pretty impressive looking facility. But my point here is design does affect BPSD. So where you get that right, you're going to get less BPSD. Let's think a little bit about interpersonal research. Henry Brodati is a professor in Sydney. He's done a lot of research into the dementia sector. You might have heard of him. This is a paper I'll just present briefly, which was really a meta-analysis looking at interpersonal research. So skills training for caregivers, improving communication, problem solving, role plays, improving recipients' experiences, education for caregivers, all sort of really basic things. Activity planning and environmental redesign, enhanced caregiver support and self-care techniques. So nothing to do with medication, but everything else. And when you start to look at that, there's reasonable evidence that this favours the intervention, this favours the placebo or the control, and all of these studies would say that all of those things have actually been quite helpful in reducing the amount of BPSD that it's experienced by the patients. So I think some of those simple interventions can be really helpful. There's the Walking in Another's Shoes, you might have heard of that, run by Matthew Croucher or designed by Matthew Croucher and Susan G, and started in Canterbury, and that's just an educational session for caregivers that they go to, and it's been really helpful in thinking about the person and what their needs are in a kind of role play type of way. So it's a really powerful way of reducing BPSD, our responses. Here's a paper on person-centred care and dementia care. So person-centred care is a fashionable term at the moment. Largely means that you know the person, so you know who they were, you know a bit about their past, their hobbies, their interests, and you can use some of that information in their current setting. Dementia care mapping is a different approach where you might go to a residential facility and you'll just observe what's going on, and then you'll feed back to the staff after 2 or 3 hours. I noticed that John over there was doing X, Y, or Z, and you did this, and you're noticing that John and Clara aren't getting on, and so you're observing, and then you're feeding back to the staff and seeing if you can get an intervention which might mean that there's less altercations, for example. So both of these things are slightly different, but they're trying to match the environment. And when you do these things, you get less BPSD, you get less response. So how you respond to people does affect what happens to them. This is just a slide to talk about language and thinking about our patients, because the way we often describe them and what they might say about themselves are two separate things. So from a clinician perspective, they're confusing their words, they're trying to hit out, trying to get out of bed, they're withdrawn, they're convinced someone's stealing things, or they're resisting when staff try to assist with shower. Resisting is quite a strong word. Whereas the person themselves might be thinking, well, they're speaking quickly and I don't understand, I'm afraid, don't know what's happening to me, I can't sleep on my own, I miss my wife, I'm bored and I miss my garden, I hear things at night, lights are on at night, I can't find my glasses, people are here are too busy to help me. So there's quite a contrast between what we as clinicians might be thinking or saying and what the person might be thinking or saying. So it's important how we think about things, what language we use, and what's the experience of that person. Last slide on non-pharmacological. This is just another study. It's fairly old now, but the use of music. Here they give music to a group of people who are agitated, and of course the agitation is a lot. This is normal. This is classical music, so a bit of a reduction. But where you have music that is particular to that person, whether they like country music in the past, and then you put country music on, you get by far a greater effect in terms of reduced agitation than you would with just normal music. Interestingly, that doesn't last though. So 30 minutes and then starts to creep up again, possibly as they get bored or something else happens. So the use of music is important. So there's lots of techniques like that which I think sometimes we don't use enough of. Right. Any questions on non-pharmacological things before I go on?
Just think about those patients with a really high falls risk, and especially kind of getting up at night and falling. What about things like cot-side, bedsides and alarms on the floor and that sort of thing? Are they appropriate to be using?
Are they what, sorry?
Appropriate to be using?
Yeah, well, certainly in hospital we do. I think the tendency in hospital now is to reduce a mattress on the floor sort of stuff rather than having people in beds where they can fall out of beds, so it's less restrictive so they can just roll over. There have been situations that I've been involved in where we have 3 or 4 mattresses and that becomes the floor and they sleep wherever. I don't know if you've got a view on that, Jan?
Certainly the research is ever increasing that cot sides actually cause more injuries than prevent. And in fact, they're not normal, are they? You don't have cot sides on your bed at home. And if you're in that situation, as Adam's saying, where you're feeling, where's my husband, I'm in a strange bed, your inclination is to climb over them. So, these days you can get what are called go-low beds, which do go very low, so if the person rolls out, particularly if there's another mattress there. So you can minimise risk without too much restraint in some cases.
Okay, and those are environmental changes, aren't they, reducing? Yep. Any other questions on non-pharmacological before we move on? Okay. So I'm going to start with this quote from Voltaire, a few hundred years ago, I think. Doctors put drugs of which they know little into bodies of which they know less, for diseases of which they know nothing at all. And there may be some truth to that. So be careful. This is just a slide to capture the amount of drug research back in 2010 that was going on around the world in terms of Alzheimer's. It's quite a nice slide. You can see in the middle here, these have got to phase 4, donepezil, rivastigmine, galantamine and memantine. You will have heard of some of those. You possibly used some of those medications. So they've got to the point of use. And then there's a whole lot of others that are sitting on the outside, and they're all looking at different things. So reduced amyloid beta production, aggregation, clearance, and then there's some for tau. There's some looking at cholinergic things. So there's a lot of drug research going on out there in the world today. So when would we use medication, and more importantly, when would we use medication in regards to BPSD? I think this kind of sums it up for me. Where there's moderate to severe, where the BPSD is moderate to severe, and the impact on a patient's or caregiver's quality of life, functioning, or that poses safety concern, often in conjunction with non-pharmacological interventions. So, and it's not the only thing, and you've got to think carefully about what you're doing, why you're doing it, and what you're trying to treat. This is the Health Quality and Safety Commission New Zealand website. Has anyone seen this Atlas of Variation? Some of you might have. I'm quite fascinated by it. So if we just think about medications, this came from the polypharmacy, or older adult polypharmacy, I think, part of it. So you can look at this if you like. So this is people who received an antipsychotic in 2014, aged between 75 and 84. And you can see if you're in Northland, the levels were a lot less than they were in the whole of the South Island, bar South Canterbury. So the South Island's using a lot more antipsychotics than the North Island for that age group. It's kind of interesting. So the darker colours are into the 30s per 1,000 people versus the lighter colours which move into the 20s.
Doesn't match up with
patient numbers per prescriber? So say if you've got one doctor per 1,500 patients versus one doctor per 3,000 patients, because you'd think the north may be under-doctored or under-prescribed?
Under-prescribed, yeah. So I guess I'm not sure on that, but I'll come to that in a minute with something else. I guess, I guess there's no right or wrong here. It's hard to know what's the right amount of antipsychotic to be prescribing, isn't it? So I'm not making judgments about the South Island.
Sorry, can I just say that's based on dispense data?
Yeah.
So it was just medicines dispensed, not prescribed.
Right, yeah, that's right. But you assume most of them would have been...
Well, if you were prescribed a medicine and you didn't pick up your prescription, that wasn't captured.
Yes, okay.
It's only medicines that were dispensed by a community pharmacy.
Okay, so not everyone has not necessarily always taken them.
Yeah.
Okay.
Do you think there's a cultural aspect as well? Cultural aspect?
I do, yeah, and I'm going to come to that, which is kind of interesting as we go along. So hold fire on that question. Here's another one. People dispense both an antipsychotic and benzodiazepine or Zopiclone. So that was just really just to illustrate that the map's not static. So again, there's a bit of movement here. So there's less going on down in this area, a little bit still in Canterbury. And so the map is different when you look at the two. So each thing that you look at, it does change a bit. So I think it's useful to reflect on, really. This I picked up on within that map. So this is across the nation, ages 65 to 74, 75 to 84 and 85 plus in terms of antipsychotic prescription. And it just goes up. Same down here, benzodiazepines or Zopiclone, it just goes up. Now, is that right? So why does it go up? That's not in any particular area, that's just generally. So we're prescribing more antipsychotics and more benzodiazepines and more Zopiclone to our elderly than we are to people who are in the 65 to 74 age group. So this is a study that was done by a colleague of mine, Ceres Barathan, who works in South Canterbury now. And it kind of picks up on some of those questions that you've asked. So he compared Canterbury to Bay of Plenty, two different health boards, and he wanted to see what was being prescribed. So you can see there males and females in Canterbury are getting more antipsychotics, and it's going up with age, again similar to the slide I just showed you. And in Bay of Plenty, same sort of pattern, a little bit less. What were the antipsychotics being prescribed, he asked next. So methotromeprazine, a little bit of. Risperidone, which is the only one that's really formally licensed for this age group when you kind of look behind the scenes in New Zealand. Olanzapine, a bit more in the Bay of Plenty than in Canterbury. Quetiapine, up there. Some people would say vitamin Q, because it is being bandied about quite a lot. And haloperidol, quite strong in Canterbury, less so in the Bay of Plenty. So slight discrepancies between those two DHBs. What was the context of the prescription? So this is interesting. So 41% palliative care. Yep. So that's a reasonable amount. About 40% BPSD. And then these are probably patients that may have been in the mental health system for a while, and that's not prescribed for a BPSD reason, that kind of stuff. So 40% BPSD when you start looking at behind the scenes at this particular study. Then who is prescribing? Because there's been big arguments about this. The GPs, some of you guys would say, oh, it's all the specialists. The specialists say, no, it's the GPs. And so who's doing all of this prescribing? So this was quite interesting. So he looked in, so this is the frequency of prescribers. So Bay of Plenty is a smaller DHB than Canterbury, hence there's less prescribers, right? Because Canterbury's a big one, so there's less in the red. So most people are prescribing between 0 and 10. Just over 200, and then it sort of starts to fall off. But approximately 1/7 of the prescribers were involved in 3/4 of the cases. So that someone here was prescribing 60 and 70 antipsychotics. So those might be people that work in an area where you would expect that, but it might not as well. And there were a few rogue prescribers, if you like, who were just prescribing it for everything all the time. And that takes up a significant amount of the prescription for that base. So we have to sort of educate everyone in a way. I think those individuals were GPs.
Can I ask what time the study was done?
About 3 years ago.
Events in Christchurch, that could have had quite a considerable...
Oh, it was about 3 years ago.
So post...
Yeah, post-earthquake, I think, yeah. He presented this in 2013. I don't think it was published, actually, so... but I think it's a good study in regards to what's really happening out there in terms of how he looked at the information. So it's just food for thought. Right, so that was that bit. I wanted to talk a little bit about this study here, which is called the CATIE study, Clinical Antipsychotic Treatment Intervention Effectiveness Study. It's CATIE. We'll call it CATIE from now on. So this is a US study. It's quite an interesting study, and it was looking particularly at antipsychotics in the elderly, and its outcome was, do the people stay on the medication? That was kind of their main outcome, which is different to most outcomes in studies, which are, does it work? Does it make a change to the neuropsychiatric inventory? Does it change anything there? And it considered situations outside of residential care, so largely people in their own homes or in assisted care, so not the hardcore end of the spectrum in terms of residential care, so people that are wandering around in their own homes but experiencing delusions, hallucinations, aggression or agitation. And follow-up was greater than 12 weeks, although I'm only going to focus on that today. It went through for 36 weeks, I think, which is also slightly unusual in regards to a study. It's quite a comprehensive study. There were 421 participants across 42 sites across the states. So they were moving around, still living at home or in assisted living, and family members were involved in the study, just slightly heavy on the female side, 73% in own home. That gives you a bit of a context of who these people were. So it compared placebo, which was double blind, so they got pills as well, versus olanzapine, quetiapine and risperidone. Okay, so 3 antipsychotics and a placebo tablet, and you got randomised into one of those groups. So phase 1, so once you got randomised, then at any point in time, the doctor looking after you could change the antipsychotic. So you could increase it, or you could change the medication. You could increase it, or you could go for another one if you didn't think there was benefit at any point in time. So it kind of matched clinical practice. That's what you do. You see behaviour or you see hallucinations, you treat, and if it doesn't go away, you say, well, I'll either increase the dose or I'll go for something else, or I'll stop altogether. So it kind of matches what we kind of do clinically. And then phase 2 of the study was if you hadn't done that one, then you moved on to a different one. So the main aim was to look at the length of time patients stayed on their assigned treatments as the primary measure of treatment success. Okay, so different to lots of studies. And the average final doses, olanzapine was around the 5 milligram, quetiapine 56, and risperidone 1 milligram. So moderate to small doses. What do they find? So there's big fall-off rates, as you might expect. So the N here is the starting number of each patient. Olanzapine's purple. Green is quetiapine, blue risperidone, and yellow is placebo. So in the placebo group, 138 started out, and by week 12, 47 were left taking placebo, right? And so in the olanzapine group, 98 started out, 40 were left at the end taking it. So there's a big fall off in all of the groups. They were allowed to stop if there was no clinical benefit or if they got side effects. So you'd expect that possibly in the placebo group there'd be no clinical benefit. That's what you'd probably be thinking. That being said, there were still 47 of them taking it at the end. So it says, yeah, it was 2 for the placebo group and then 1, 1, 1 as they divided it up. But you can see also that there is a significant difference between the medications in terms of this measure, which was the neuropsychiatric inventory, compared to placebo. So you are getting a reduction in behaviour from that, and you're also getting it in the BPRS scale. So for those people that stayed on their medication, you are getting a reduction in hallucinations, delusions, agitation. But the important thing to see is there's only a small proportion of people who originally started out who are tolerating or getting benefit, which is about a third. So in phase 1, there were no differences in the length of time in treatment among any of the 4 treatment groups. So they sort of matched each other in terms of their fall-off. Those taking olanzapine and risperidone were less likely to cite lack of benefit as a reason to discontinue use. So it might have been working to some degree, but then they couldn't tolerate it. And participants assigned one of the 3 antipsychotic medications were more likely to discontinue use because of intolerable side effects than placebo, which is kind of what you would expect. So what does that mean? The overall benefit of these medications is offset by intolerability to associated side effects. We do need to think about that. Although some patients may benefit greatly from these medications, the evidence from this study suggests these medications hold limited value for the majority of patients, which is why I was talking about non-pharmacological first, and then if that's not working, maybe then pharmacological. We have to just think about that. Limitations, you could argue that there's suboptimal therapy here. The dosing was smallish for some, and maybe they would have benefited if they had higher doses. Don't know, I thought they were reasonable. Choice of outcome, how do you compare this study to other studies out there? Low event rates they found, so we do think antipsychotics contribute to risk of stroke potentially, but that's a low event rate, so it's a bit hard to untangle how that all works. And generalisability is this, it was a particular group of patients, they all potentially had Alzheimer's disease, didn't have Lewy body disease, didn't probably have vascular dementia when they were looked at, so it's not generalisable to every single dementia out there. Let's talk about withdrawal of antipsychotics, and this is what we don't do well, and I mean we generally. It's easy to start a medication, it's hard to stop one, and what happens when you do stop it, and there's always resistance to stopping antipsychotics, particularly in residential care. Do you guys find that? I certainly do, because people get worried, well, what if? But there have been studies out there which look at stopping medications or at least withdrawing them. There was one done in Auckland recently. I was trying to find the data for you, but I couldn't because I don't think it's been published. But they effectively went into the care facility and either stopped or reduced all medications in that facility. It's only a small proportion of people that needed to go back up, about a third that needed to go back onto medication. So 2/3 of them were getting them when they didn't really need them in the longer term, which takes me back to that original slide that this is dynamic. So if you have hallucinations now, you might not have them in 6 months' time. So we should be, when we start a medication, we should be thinking about when and how are we going to stop it. So predictors of successful discontinuation, according to these studies, which all looked at reducing or stopping medication, was at lower rates of antipsychotics and low baseline severity of behavioural symptoms. But those are the questions we should be asking of ourselves as we go along when we've started medications or attempting to stop them. But it's the harder path, it's the harder course to do. So overall, both atypical and typical antipsychotics appear to carry an increased risk for mortality and stroke in patients with dementia, so they're not insignificant medications. These should be prescribed only after discussing risks and benefits, and their use should be re-evaluated frequently. Atypical antipsychotics are preferred over typicals for BPSD generally. I'll just touch, I'll go for 5 more minutes and then we'll stop for questions. Antipsychotics are most effective in the treatment of psychotic symptoms. So if you've got psychotic symptoms and someone's distressed by them, that seems a reasonable place to use it. If you've got agitation and aggression, and that's the rate limiting step between someone going into care or not, then there's good reason to use them. So you just use them judiciously. All patients should be informed of the potential risks. Cognitive enhancers. Do you guys use cognitive enhancers a bit? You would have seen them out there. What's their place in regards to BPSD? There is some evidence out there that they do provide some assistance for some patients some of the time. But how do you know which? I don't know. I'm always of the view that it's worth a go if they're going to accept them, if they're not going to clash with anything else, and if there aren't any other contraindications. Then if it was me, I'd like to try it personally, is where I come from with those. Here's a study here, this is 2003, systematic review of cholinesterase inhibitors looking at BPSD, and they did show modest benefit on BPSD. So sometimes you do get improvements. They're also quite useful with apathy, which is what we sort of touched on at the start. The apathy, then maybe you might get some improvement with your patients with dementia. So I always think they're worth a look, or at least thinking about. And sometimes you get improvement with hallucinations, and if you've got a Lewy body type of picture with Parkinson's disease, then they might be your go-to agents to begin with. This just explains this is cholinesterase inhibitors again for the neuropsychiatric inventory, a few studies there leaning towards assistance with BPSD, and again down here, different scale, mostly leaning towards assistance, a couple that weren't. So they may have a place in trying to treat BPSD. Antidepressants, they can be used for agitation as well, and there's actually a bit of evidence out there on those, particularly for citalopram. Modest efficacy here. Best evidence for sertraline and citalopram. Maybe Alzheimer's disease may be more responsive than vascular dementia. Some evidence that citalopram is useful for agitation or psychosis. Here's another study looking at sertraline versus placebo. This one actually didn't show any difference in terms of the mood symptoms or the BPSD. So it's not equivocal. It doesn't mean that every single time you use it it's going to work. And there are consequences of prescribing SSRIs. Antidepressants versus antipsychotics. There have been a few studies out there on that. Citalopram versus risperidone here. Interesting, citalopram helped with the agitation score in this study, and they both decreased psychosis. So there is a place for antidepressants potentially in this group. And then anticonvulsants. This is sort of second or third line. I don't tend to use carbamazepine myself, but there's limited evidence for valproate, although some people might use it when they're getting a bit stuck and you're getting mood lability and those sorts of things. Then maybe sometimes anecdotally you get improvement, but it's not that well described in the literature as it stands at the moment. Right, I hope I haven't confused you. I got two more slides. Right, here are the takeaway points. BPSD is complex, requires a good understanding of biological, interpersonal, environmental and psychological factors to make an appropriate intervention. Think non-pharmacological first, and hopefully those little stories I illustrated to you means that sometimes there is value in thinking about that person in a bit more depth. And when starting medications, consider the target symptoms you're treating, monitor and consider when you might stop that medication or how it might be stopped.